Now it's my pleasure to welcome Dr. Mehmet Oz, Administrator of the U.S. Center for Medicare and Medicaid Services, Mr. Patrick Conway, Chief Executive Officer of Optum, and Dr. Clive Fields, the Chair of the Center for Medicaid Service Healthcare Advisory Committee, up to the stage. Dr. Fields will be moderating a panel discussion on the critical importance of national standards. And Dr. Fields, the floor is yours.
Tim, thank you very much. First, a good morning and a thank you to Carissa and to Mrs. Burgum for your words. They are always appreciated and deeply felt. And thank you to all of you who persevered, planes, trains, automobiles, whatever it took to get here today. It sounds like weather was a real challenge for many of you. My name is Clive Fields, and I have this somewhat enviable task of introducing two physicians that require very little introduction. First, Dr. Mehmet Oz and Dr. Patrick Conway. Most of you, and I hate to sound so familiar, but I'm going to call, Dr. Oz sounds like a first name, but Mehmet,
I don't think I can hear you.
Dr. Oz sounds like a first name, Mehmet sounds like a first name, so I hope that you don't mind if I take a little bit of familiarity and refer to you as Mehmet here today, especially in this building. But Mehmet is a cardiovascular surgeon, currently the administrator of CMS, and I would be remiss if I didn't tell Mehmet that I trained at Baylor, and many of my professors would see his current job as a significant step down from his previous work as a CV surgeon. Dr. Conway is a pediatrician who has previously served as Deputy Administrator for Innovation and Quality. He has run CMMI, President of North Carolina Blues, and is currently the CEO of Optum, I believe the largest physician organization in the country. Neither of you physicians come from a behavioral health background, but you're here today really making a commitment just by your presence to the importance of behavioral health. Patrick, at Optum was a first mover in looking at standards and guidelines and as a way to quantify both treatments and outcomes in behavioral health. I would love to hear a little bit about how that journey started and some of the challenges along the way.
Yeah, so first, pleasure to be here. Thanks for having us, Dr. Oz, Dr. Fields. You know, for me, this is personal, as it is for so many Americans. I've experienced the mental and behavioral health system as a person, as a family member, and in both the public and private sector. I actually served in this building in the Bush, Obama, and first Trump administration in different ways. And I'll tell one story. You know, was with Patrick Kennedy at an event where we committed, I at CMS and at the time many private payers, so some corollaries to this event, to measuring quality back in the day with PHQ-9 for depression and other things, putting that into programs, committed to the collaborative care model, which at that time was the CMMI model, and how do we scale that nationally. So this has been a journey. For Optum, you know, we have a large benefits and care delivery organization that serves payers, employers, governments across the country. And for us, it's just a pleasure to be here to commit with partners in this room. And we've worked, I'm looking in the audience, with Psych Hub, Kennedy Forum, professional societies, so many of you across this room, to clinical care pathways, to quality, to access, that the mental and behavioral health system has to be like the rest of our system. If this was cancer and you couldn't get access or you couldn't get quality or you couldn't be on a clinical care pathway, and you know this well, in the cancer arena, we put that into place, you know, decades ago, and we've seen the improved outcomes. We have to do that in mental and behavioral health to deliver whole person care that delivers high quality, evidence-based care to all Americans.
Mehmet, lots of priorities at CMS, but you've made access to behavioral health, especially in rural and underserved communities, a priority. Tell me a little bit about that path and how that work is going.
So surgeons fix things. We're going to trade seats. Your mic's on the wrong side.
There you go. This is a guy who's been on TV a few times.
Yeah. Give him the water. I tried the Rube go over my mind, but I realized yours is messed up, so it's not going to work. So
there you go.
Now it'll work for both of us. All right.
You can tell who's in charge here.
That's right. By the way, Oprah always sat on that side of the stage, which is why all talk show hosts sit there, because the entryway to the stage is over there, and she never liked how her shoes fit. So she didn't want to walk too far. So their entire vision of daytime television will change now. It's based on very subtle things, like most of the big decisions we make. A lot of personalities involved. And Clive, as a good friend, I want to correct one thing you said. You said that as a surgeon, mental health issues Pat as well, not in the psychiatry business, that mental health issues really aren't our domain. And it turns out that if you don't deal with the psychiatric and emotional issues that your patients face, you can't do any of the things we do. Frankly, I don't think any doctor can practice. And I know that for primary care physicians, that's about 50% of the reason they're there has an underlying emotional nexus. It might be that their diabetes is out of control, which is why they came back, but the reason their diabetes is out of control is because they're so depressed and angry about something else. They're not taking their metformin or their insulin or whatever they're supposed to be taking, and so they begin to slip. In cardiac surgery, if you're in that room, you're scared. And the conversation that we're about to have is one where I'm going to have to at some point describe a mortality risk. There is no heart surgery I'm aware of that doesn't have a mortality risk. And if someone comes by themselves, it's a bad sign. Because in your time of need, you should be with community, you should be with folks. And COVID taught us certainly how the damaging impact of loneliness. The prior Surgeon General felt so strongly about it that quantified it as 15 cigarettes a day, as you're probably all aware of. But the actual human cost is one that is addressable if we intervene. So in my case, I would tell patients if they came by themselves that I needed them to come back again with someone that cares about them enough that we could celebrate together about their survival if they had the surgery. And they'd say, well, I don't have anybody in my life, which is, again, a bad sign. But invariably, there was a doorman, a delivery person, an estranged cousin. Someone was in their life that actually does care about them. And reminding themselves that that's true was an important part of my interaction with them. At CMS, we have, and we're going to talk about some of the pathways that have been crafted, some under Pat's guidance years ago. They're out there. One of the big challenges we have is people don't realize they're out there. Your primary care doctor doesn't have to be the only one who manages you. We have clinical care pathways that actually, just like we have them for diabetes and cancer and other ailments, we have them for emotional challenging. You have to actually have a diagnosis to get access to these. But when people don't know to ask and no one tells them, and it's seen as a side issue, not the main course, the entire system begins to falter. And that's why evidence-based systems that drive quality so that we can have accountable organizations deliver that quality are so important. But even there, we have a problem. And I'm just going to say that, there's an elephant in the room here. You guys care about this issue. There are a lot of people who just don't have it on the radar. And so if you're not focused on it, you're not going to deal with it. Why is it that the numbers of physicians in accountable care organizations has not increased? It's been stagnant now for years. And the reason is the bottom half of the quality pyramid doesn't do quality well. That's why they're the bottom half of the pyramid, so they don't want to be in these accountable care organizations. So the people who come to these kinds of consortiums and sign the pledge and participate are the folks who already are doing the right things. We have to go beyond the borders that we've crafted around this ecosystem, outside the walled garden, and say, hey guys, it's nice in here, come join us. It's not just a hassle, it's gonna make your life a lot better. It's gonna help your patients more than you can imagine. Come join us.
So you touched on the value of community. And Patrick, how does United or Optum think about engaging a community in the treatment of a whole person, not just in a diabetic educator or not just a cardiovascular rehab center, but how do you think about bringing breaking down the silos that surround behavioral health and addiction in a way that drives the kind of success that Mehmet just referred to?
Yeah, I'd give two examples. One, interestingly, tomorrow we'll be announcing a community investment in Tennessee. So we think very purposely about how we invest in partnering communities. I also see Dr. Ree from the community health centers. How do we partner with entities, providers across communities, investing in social drivers of health, investing in mental health support, investing in prevention. Dr. Oz brought up a great point on the accountable care and how do we move the whole parameter. I mean, our physicians and clinicians are in accountable relationships where they're responsible for quality, experience, total cost of care. When you're in that environment, you know that integrated mental and behavioral health care produces better results. There's strong evidence on this. So you deliver via physicians, via therapists, via psychiatrists, via social workers, via the whole care team. You treat for that whole person as part of the community. We've also got our Chief Medical Officer of Optum Behavioral Health in the audience. As we serve our clients, we talk about the importance of access, integrated care. How do we get access to your employees? If you don't mind, I got to call out 3 things he's announcing because it's awesome. It's rolling out today.
No one can write anything down.
You can write it down if you want. I'll break substance use disorder. They're rolling out right now integrated care pathways for substance use disorder, to get people into long-term recovery, to prevent, to treat the whole person over time. These are actually all real stories from our people. Jordan, a person who had struggled with substance use for many years, we wrapped that care around him. He's now employed, he's functioning well, he's with his family doing well. Serious mental illness. Sorry, I promise I'll talk less than you, but this is important. The patient stories are great.
I talk too much.
No, you're a better talker than I, by far. You're like 100 and I'm 2.
Don't feel bad. I'm with you.
Yeah, we're twos together. You're a 10. Serious mental illness. Avery, had struggled with schizophrenia throughout the lifetime. Get on a long-acting injectable medicine, better adherence, wrap around clinical care pathways, whole person care, investing in community. Once again, getting them into a productive life, them and their family. The last, autism spectrum disorder, which actually has 2 components here. One is early identification, treatment, holistic care, not just ABA. ABA is an important component, and I'll come back to that, but physical therapy, occupational therapy, primary care, the whole spectrum. I grew up, I'm a pediatrician, I still practice, I still see kids in the hospital. I grew up with a lot of people don't know, with a cousin with autism who never got the care she needed, ended up being institutionalized for 50 years before she died. That is bad for her, it's bad for the family, it's bad for the system. Now the flip of this is we're also going after fraud, waste, and abuse. You do have providers in autism, a segment that are bad actors, and you have to go after that because you need to have that not in the system, if you will, the bottom of your pyramid, and focused on the high quality. So thanks for letting me call out some of the great work from the team, but it's just an example, once again, through partners, you focus on some of these important areas and you provide services in mental and behavioral health just like we would expect of any other part of the health system.
No, I mean, you bring up
Where's your leader? Where's your...
Dr. Paul.
Stand up. So this is, torture him. But thank you for doing that.
Just listening to the innovation inside Optum, it makes me think. I mean, Mehmet, you run a huge public agency. Patrick, you run a huge private organization. But innovation doesn't come from just small, nimble companies in the Silicon Valley. It's actually coming from large organizations like the ones that you run. Is there anything that you could share as to how you succeed in actually successful innovation in companies and organizations as large as the ones that you lead?
I'll start with the Rural Health Transformation Fund, because one of the things we can do is put our money where our mouth is and begin investing in areas not to pay the bills, but to actually transform the system, to right-size the system, which doesn't mean smaller. So it's got to be bigger in some areas, often in mental health care, and smaller in other areas because we're not delivering value. So when the Congress and the President, and this was a vision that they had and they wanted to put out there, to change how 60 million Americans see their health care. 60 million Americans, rural America, who have a life expectancy that is years behind that of urban America. And if you look at all the places where they're falling behind, and there are a couple of very clear examples, you can't pass mental health as the leading example. 2/3 of rural counties in America do not have a psychiatrist in the county. 80% don't have adequate quality access to mental health services. So people say, well, put more psychiatrists out there. I mean, how many psychiatrists are in the room? Put your hands up there. It's just hard to get you guys to move to rural America. They're just not happening. It doesn't matter how much we pay for these things. And yes, we have telemedicine and other pathways that we can try to use, and we are funding these programs accordingly. But the real thought behind the Rural Health Transformation Fund is let the governors who know their state and love their state, but they definitely have insights about their states that are different from the ones that we'll ever have in Washington. Let them come up with better ideas. Most of the states came back to us with mental health integrative pathway programs. They have different ways of doing it. We have a lot of states that are now using schools as a nexus for healthcare, which I think is pretty cool. If you go around the country now, most states have vision checks in elementary school. Why do they do that? Why don't they just go to the ophthalmologist? Because no one's taking a second grader, a 7-year-old out of school, going to a optometrist to get examined, and then go later to an eye doc to get the prescription filled, check the prescription. It just takes days out of the life of the kids at school experience, but also the moms don't have the time. And there's often these moms are the ones that are having the most challenging effort pulling all the pieces together. So they do that for eyes and eye care, and they do it because it's more efficient. Now we're doing it for kids in school as well, providing more on-campus services to those children. Same thing is also true for the ability of primary care doctors in rural America to now get access to mental health pathways. So access to a psychiatrist and a mental health coach or manager who can coordinate these efforts. So maybe the primary care doctors in your small town, but the mental health manager can get access to a psychiatrist in a larger urban center that can triage a diagnosed illness. It's those kinds of rewiring of the system that help. And I'll give you the last and really good example. If we have world-class expertise like we have in this room, but it's all siloed in the ivory towers of academia, if we can get the grand rounds, for example, to be more inclusive, so smaller centers or clinics can actually participate. Now, all of a sudden, there's an exchange of best practice that's cultural. It's not just intellectual. It's not a test. It's how do you, in practice, deal with this problem? And what's the newfangled idea that might actually work so I can begin to incorporate it in my smaller community? That hub and spoke model is working very effectively. It's working in more traditional approaches to physical medicine. It should work in mental health services, and we're putting a lot of emphasis behind that. And I want to just call out Secretary Kennedy, and I don't know, Ms. Burgum has been a huge leader in this, but the two of them had a great EO that they pushed hard and the president signed to ensure that this was on the nation's agenda. And they've been cheerleaders continuously. And Bobby obviously has had his own personal experience, which I'll speak to when he comes later in this session. But it is the MAHA movement fundamentally is about making it easier to be healthy in America. It has to deal with mental health issues. And Pat, you have been a leader both in this agency, but also when you went into the private sector, taking that same large-scaled approach so that you set a North Star. So a lot of the insurgent companies try to keep up with the incumbents, and they do it by looking at what the incumbents are up to and aiming at the same targets. And it has been a very effective leadership model. Thank you.
Look, I appreciate you saying that. Just, credit to Dr. Oz and Secretary Kennedy for this event. You asked about the public and private sector. I was the longest serving deputy administrator, chief medical officer, and director of the CMS Innovation Center by a wide margin.
Why didn't you leave?
Which shows you, I actually believe in scale and impact in service. It's about that simple. But I will say this, I said this internally one time, it was the hardest job I ever had because it's really challenging every day. So thank you for your service and the teams here. And a credit to you, you're setting the incentives, the outcomes, the expectation, the pledges that you want out of America and all the people in the room, and that's amazing. On the private sector side, to answer your question, we are trying to disrupt ourselves, which is hard as a large organization, but we serve, you talked about rural, and I grew up in a smaller town in Texas. We serve about 90% of rural counties now. We can get a nurse or a nurse practitioner into the home. And then we virtually serve the other 10%. We're doing a lot of work. How to use AI, how to use technology, how to use collaborative care models. How can we reach every American with that access to care? You alluded to it being in all communities. The AI story I tell internally and externally is my first week as an attending at Children's Hospital of Philadelphia, I get a kid who'd gone all around America. This was not mental and behavioral health. Ended up being a rare mitochondrial disorder that he had gone around America for 2 years. And on page 487, figured out the diagnosis of a paper chart. In today's world, using AI, that child should be diagnosed anywhere in America and treated. That child or adult with a mental and behavioral health disorder should be treated. I told you I wasn't going to share this story. It's going to I get a little emotional sharing it, but a while back, I had a 14-year-old who I cared for in the hospital. She showed me in a book 100 therapists and psychiatrists, and she had insurance that she tried to get to in the Boston area.
Wow.
She knew she was severely depressed. She knew she needed help. She actually tried to use substances to self-treat. She then went to the top floor of her, which is luckily only a 3-story building, jumped off, it fractured both of her femurs. We've now fixed her legs, and we're looking for appropriate outpatient therapy. That should not happen in America. That child, is somebody's sister's daughter, et cetera. That should not happen. So the work we do together across the public and private sector should prevent people like her from falling through the cracks, so they get the care they need earlier, and they all get the care they need, which I'm in for.
Yeah, I think for everybody in the room who's directly taking care of patients, whether an ER, an OR, or an exam room, that we've all had exactly that type of experience. And we all want to do something about it. And is that it in technology? Is it in therapeutics? Is it in payment reform? What are you thinking is necessary so that young lady doesn't have a daughter that experiences the exact same thing that she did?
Well, folks don't want to talk about AI very much, but it does start to address some of the concerns that you're raising, Clive. And when Pat said that about the mitochondrial disorder, which, as many of you know, might be the root cause of a lot of the autism, certainly, that we're seeing, it's hard to diagnose it because people don't look for it, and you don't know what you don't know. So one of the beautiful things about technology, if we can use it wisely, and in this room 2 days ago, we had the 1-year anniversary of the digital tech ecosystem that Amy Gleason has crafted. With the President's support and Secretary, he's been continuous. Well, I still have it. I'm still here. I'm not gone yet.
I'm your tech support.
Tech support, Pat.
It's expensive tech support, by the way.
The irony is that when you ask Medicare beneficiaries, where we have a lot of good data, 2/3 really don't trust AI, and for good reasons. I mean, think about it. When was the last time you saw AI as the hero of a movie that you watched, right? AI is almost always the cause of some dystopian, post-apocalyptic world that understandably raises concerns that could happen again, because art predates science, it predates our culture, usually. Artists connect dots that many of us don't see, and even if they're not connected the right way, we tend to see things in that Rorschach test that compel us to believe that's the future. But if I think about healthcare, which is the one exception to that rule, the one place where the average person says, you know what, I could imagine having a really smart coach in my pocket that maybe AI informed or driven, large language models will be modified so that, you know, if I ask certain questions, I might not get an answer, because that's one of the art forms in medicine, right, Pat? Sometimes parents ask you a question about a kid, and the right answer is not the answer to the question they're asking. A good example, how do I commit suicide? I mean, there's many, many possible ways of answering that. But the most important thing you do is pivot to the question you should be asking. And right now, eventually, the models will answer that question if you keep pestering them enough, because they're designed to answer your questions. But we've seen tools, many of you have witnessed them as well, where that number of times that you might actually get an answer that might help you hurt yourself is under 1%. That begins to approximate what a human would do. And those are the kinds of models we're looking at. We need to have different payment structures for those. They cannot be based on CPT codes. It needs to be based on holistic total cost of care, I think. And if we can build accountable care organizations using these tools to support doctors and nurses taking care of mental health issues, it'll be helpful in ways that are beyond even our imagination right now. But let's be clear about the major limiting factor. It's each of us. I mean, half of our frontal cortex is geared to read the face of the person you're looking at right now. There's a reason we're biologically hardwired to look so carefully to people around us, because we're uber social species. I can tell from subtle little looks in your eyes if you're bored by what I'm saying, if I'm willing to pay attention to it. Sometimes we ignore it. That's a whole separate problem. But if you're actually trying to connect with somebody, that's a remarkable skill set we have. It's hard to scale that. And we've taken the traditional role of family out of this. And I went to actually an event with Patrick Kennedy, that beautiful event they had at the Capitol building, and the question was, how do you scale human connectedness through the healthcare system? And I don't want to ask the healthcare system questions that is not really well designed. You don't want the healthcare system paying your mom to talk to you. That just sort of happened that's part of the deal. She made you. And we're trying to do that, unfortunately, in some ways that I don't have confidence are going to be sustainable. But there might be ways to get you to talk to your mom. And I was just looking at some data from LA County, which is really having a homeless crisis. And just looking at those numbers, example, of 100 homeless people, 10 of them need big-time, big-ass medical care. Like in a hospital with a professional medicating you probably, or at least dealing with your substance in a very comprehensive way. 90% of the people aren't, though, in that category. And for them, they need other types of social support that might not all have to be within the healthcare system. And we should be thoughtful about ways we can bring other stakeholders into this mix and empowering them to help with those folks. How are you guys doing with this at United Healthcare? Because, I mean, many of these folks obviously are your constituents.
Yeah, look, on fixing the system and answering that question, like many large system issues, I think multifactorial. I started work in this building almost 20 years ago. I want us to go faster. But one, standards and evidence-based clinical care pathways, one of the topics today. Measuring quality, reliably focused on outcomes, and that we improve those outcomes over time. Access standards that are known, measurable, deliverable. And we're doing all these, by the way, at Optum. Tailored clinical programs for the patient. You hit on this too. So you really understand the severity of the disease, the whole person. How do you tailor the program to them, if you will, with the clinical programs, the interventions. Payment, you hit on this as well. Total cost of care, quality experience, value-based care models work. There's, although this gets debated in this town now every once in a while, they do work. The evidence is quite strong, just for the record. Definitely better than a fee-for-service system where we're just paying by widget, regardless of the outcome. And you worked on this as well. I think those are some of the component parts. We talked about workforce and technology. I'd call those out as well. Then I think the question in front of all of us is, you know, I was in 19 years ago, to be specific, the first time I walked into this building. If you look at our progress for the 19 years, we've made progress due to a lot of the people in this room, but not as fast as we need to, because you still hear those stories. So I think the question and the point of, I think, of the pledge and the action is, how do we all take action over the next day, week, month, year to make the whole system better, and that continues. So if we sit here 5 years from now, we look back and say, you know, mental and behavioral health is a stellar, imagine that, a stellar system where everybody gets access, everybody gets high quality care, everybody gets the care they need, when and where they need it, and that's what we're working to deliver on.
You know, Clive, you've been asking questions. Let me ask you, if you don't mind, because you didn't brag on yourself. Clive has been a real thought leader in primary care in particular. What is the big barrier to primary care doctors wanting to be in some type of relationship with a healthcare manager, or maybe more practically, why doesn't it happen? When someone sits in your office, how many physicians do you have now?
At the peak of the organization, there were 5,500 providers.
Right, so 5,500 docs, and again, conceptually, half of the time they're talking, or at least they're seeing people of mental health issues as a driving factor. They may not be clinically sick enough to require treatment, but that's a major driver. They don't care about something that should be important to them. How do you actually get clinicians in the front lines to deal with that?
You know, it's such a great question, because I can't imagine a primary care physician that wouldn't want the kind of help that a behavioralist could bring to their patients, whether it was an LCDC for substance abuse, whether it was a marital counselor, whether it was a psychologist. The barriers that have been put in place for teamwork exist not just in primary care, but I would suspect all across the healthcare system. When you're in an OR, you have a team. There are 5 or 6 people that are absolutely committed to exactly the same outcome. I can't think, maybe in an ER, as I look at Tim, maybe the team works well there, but I've been in enough ERs, as many of you have, to know that teamwork falls apart in emergency rooms. But where it's most needed is in a primary care office, right at the start of the problem or the identification of the issue. And we look at models like the collaborative care model. We look at all kinds of opportunities where primary care doctors could team with behavioralists to drive a comprehensive, whole person type of healthcare. And I think there's going to be opportunities over the next couple of years of the administration to remove some of the regulatory barriers that stop that from happening, to refocus some of the resources. And it's not about earning more money, it's about getting paid for outcomes. And people talk a lot about value-based care, and I've been trying to use the term outcome-based reimbursement. As far as I can tell, I'm the only person that's using this term. But it makes sense that you should be paid for outcomes, because I always thought that what we did in our exam rooms was valuable, so I kind of thought I always provided valuable care. But I hope so. But as we move towards outcome-based reimbursement, and we do it through the removal of regulations and economic models that actually look at the entire total cost of care, the kinds of models that Optum has really been at the front of, I think those barriers can be removed. The idea of not working in teams now feels so completely just anti everything that we're trying to do. And that team can include a parent or a teacher or a rabbi or a priest or anybody in the community that can be supportive, as well as a myriad of healthcare professionals working to a common goal.
This all hands on deck approach does work. I'll give you two concrete examples. Abe Sutton, who you ran that group too, he basically did everything. And Abe is the head of the CMMI group, which is it's like the nuclear reactor of CMS. They come up with a lot of good models and ideas. And he has something called the Elevate Maha model, which is designed to allow $100 million to go to 30 good ideas. Many of them are mental health care ideas. Just small little pilot projects to make sure you can put a feather in your cap if you've got a good idea. We have the Access model also from there that allows us for the first time ever to pay for digital tools. And again, I'm not advocating for us to use digital tools to talk to, be your avatar and be your psychiatrist, but at least connect you into the system to navigate for you, and deal with some of the fringe cases that really, and Pat, somebody highlighted some of these. And Tim, I shot a show called New York Med, and I told the producers, when you see someone handcuffed to the gurney at dawn, interview them, because something happened that's worth hearing about. And invariably those stories that got you handcuffed to the gurney at 5 a.m., it arose from some mental health or substance use disorder error you made starting around midnight. And so we have the clues. And I also want to call out their groups that are not, like ARPA-H is doing kick-ass work, looking at large, massive shifts. They're evaluating ibogaine, for example, and other psychedelics and the role they may play. They have freedom to do things that we can't do, for example, at CMS or FDA is not able to do. But I'm being told we have to break for commercial. So if I'm correct, is that right?
I'm going to ask you one more question, then I'm going to break for you.
It says stop, 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 and don't do it, and quit.
One more question.
See, that's what happens when you change seats. I can't see over there.
It says leave, done.
Go.
How many more do you have like that?
Well, then I'm going to bring this to a close.
Well, I want to hear your
Because
last question.
it looks like stop, stop, stop is winning over here. The pledge opens by promising timely access to high-quality mental health and addiction treatment. And I think that's a goal that all of us can sign up for and recognize the value to our patients, to our communities, and to our own families. And so the commitment that both of you have shown, both in the public sector and in the private sector, is not just commendable, but it should be encouraged, it should be appreciated, it should be recognized, and it's been a real privilege to share these moments with you. So thank you very much.
Thanks a lot.
Thank you.
Awesome.
Everybody.